Hello students, we're going to embark on our discussion on the peripheral innervation. So let's first take a look at what spinal nerves are. There are 31 pairs of these spinal nerves that occur in the human body. Now the first cervical spinal nerve, with regards to its exit from the vertebral column, the first one is situated between the skull and the atlas. So you would become familiar with the information with regards to the vertebral column in that video. As far as there are 8 pairs of cervical nerves. So as pointed out in the vertebral column information video, I should say, there are 7 cervical vertebrae. However, there are 8 pairs of cervical nerves. As far as how nerves are configured, so you need to take into account how you have the arrangement of the axons relative to the entire nerve. So you have connective tissue that is incorporated into the spinal nerve. So you have endoneurium, that's the connective tissue that surrounds the individual axons. Then you have what are called fascicles. Fascicles, or one fascicle I should say, is a term that describes a bundle of axons. So one bundle pretty much incorporates a group of axons, and that fascicle is surrounded by a connective tissue known as the perineurium. So you have endoneurium surrounding the individual axons, perineurium surrounding the fascicle, or the bundle of axons. And then you have the epineurium, that's the collagen fibrous connective tissue that surrounds the entire nerve, which is pretty much a collection of bundles. And that epineurium is continuous with the dura at the opening or the exit point of the spinal nerve from the in the vertebral column. So you have endoneurium, perineurium, and epineurium. So let's take a quick look at the breakdown. So you have the endoneurium, and you'll see how this is the connective tissue that it surrounds the myelin sheath. The myelin sheath is what insulates the axon here. So the endoneurium surrounds the axon. Then when you have a number of these axons collectively, then you have what's called a fascicle, which is pretty much a bundle of axons. And then you surround that fascicle with a connective tissue. You call that the perineurium. So the perineurium is what surrounds the fascicle. And then you get a number of these fascicles, encase them in an epineurium, and what do you have? A nerve. Okay, so let's take a look at how the spinal nerve is formed. So they are formed by the fusion of the ventral and dorsal roots. Then you have, once you form the spinal nerve, then you have a dorsal ramus and a ventral ramus. So let's take a quick look here. So here, these tiny structures here, these are the rootlets. And then you have here, these are the roots. So you have your dorsal root here. You have your ventral root right here. Let me point out here the rootlets. Okay. Here are the rootlets here, here, and here. So you have dorsal roots, ventral roots, and then you have the fusion of these roots to form the nerve. So notice how you have a root here, and at about this point, actually let me move the arrow. Here's a ventral root right over here. Because at about this point, right about here, this is the location of the spinal nerve. You also notice a bulge here in the area of the posterior root. This is the dorsal root ganglion. And as I addressed in the in-class discussion in the neurobiology, a cluster of nerve cell bodies in the peripheral nervous system is known as a ganglion. So then, once you form the spinal nerve, then you have the dorsal ramus, draw an arrow to point that out. So here's your dorsal ramus, and then here's your ventral ramus right here. Okay. In terms of innervation, the dorsal ramus is going to innervate the deep back muscles. Okay. And the ventral ramus is going to innervate the muscles of the ventral body wall and the muscles of the extremities. Okay? So, the order of structures, pretty much, you can say you have your rootlets here, forms a root. Same thing here, rootlets. Then you have a root. Then we form a, in the vicinity of the ventral or anterior part, you have rootlets, root. Then you have the spinal nerve. And notice how, let me address this here. Here you have these little branches coming off of the spinal nerve. These are the rami communicans. And this is the fibers that are connected to the ANS, the autonomic nervous system. Okay. In the dorsal region, you have the rootlets, then you have the roots, then you have a dorsal root ganglion, and then you have your spinal nerve, or I should say the spinal nerve is about here, dorsal root ganglion, and then you have your dorsal ramus. This is dorsal ramus, and this is your ventral ramus. This will come out and move in this direction. Dorsal ramus, ventral ramus. The dermatomes is simply a system that maps out the skin regions with its pertinent spinal nerve as far as cutaneal innervation or what is sensory. So in other words, if you were to give a patient an intramuscular injection right about here, the spinal nerve that's going to perceive that sensory information is C5. If you were to give the patient an intramuscular about here, L3 will pick that up. Okay, so just simply a mapping of the regions to the specific spinal nerve. Okay, the myelin sheath. This is a system that pretty much insulates the axons You recall that I addressed the myelin sheath in the central nervous system. We call them oligodendrocytes. In the peripheral nervous system, we call them Schwann cells. As these Schwann cells wrap around, so if this were a cross-section of an axon, the myelin sheath or the Schwann cell looks something like this. It wraps around the axon and then it pushes the nucleus out to the periphery, okay? And then the outermost layer of that enveloping of that myelin sheath or Schwann cell, that's the neural lemma. The nodes of Ranvier are simply the areas where there are, or the gaps in between the neighboring Schwann cells. So if I were to draw an axon, like so, draw another myelin Schwann cell, and another one, and another one. Okay, so these bare areas where there is no insulation, these are the so-called nodes of Ranvier. These nodes are the sites for the saltatory conduction. Or simply for the conduction of the nerve impulse. Here's a little link to a video that you can watch that pretty much animates the myelin sheath or the Schwann cells in relation to the action potential that was discussed in the session last week. Receptors. So you have your exteroceptors, proprioceptors, interoceptors. So the exteroceptors pretty much perceive external information in the environment in terms of touch, temperature, pressure. They are complex special senses. They have somatic sensory neurons that are connected to somatic afferent fibers. Proprioceptors, they gauge somatic movement. Again, somatic sensory neurons that are linked to somatic afferent fibers. Then you have your interoceptors, they gauge digestive, respiratory, and cardiovascular systems, or they're involved in perceiving deep pressure sensations. And these are the visceral sensory neurons that are connected to the visceral afferent fibers. Bear in mind that you have patients that are, if you happen to come across a patient that's an amputee, they are able to perceive what are known as phantom pains. And the fibers that are involved with that are the SA fibers or the proprioceptors. Now the skin has receptors. You have the unencapsulated versions, and those that are capsulated. You have these free nerve endings. Where do you find them? You find them in the epidermis. You find them in your cornea. You find them in the dermis also, your second skin, okay? What they perceive is pain, touch, to be more specific, crude touch, and they can also can determine perceive a temperature. The Merkel cells perceive, well, you find these in skin that has pretty much no hair, parts of the body, and you can pretty much, it can pick up or perceive touch. The Meissner's corpuscles, you find these in the in your palms, your soles of your feet. It perceives touch. And then the Paxinian corpuscles, you'll find these in ligaments. You find them also in joint capsules. Now, Paxinians, what they detect are vibrations. Okay. So if you look at the diagram here, this is mapping out the location of for example, a tactile cell or Merkel cell. And notice how it's linked to a sensory nerve ending here. I'm going to draw in here what would be the free nerve endings. These pretty much are located in the dermis, second skin, and they can actually pierce their way through the bottom layer of the epidermis and attach here. So here's the vicinity of the Merkel cells and the free nerve endings. Here we can map out the location of the Meissner's corpuscles. Notice how they are abutting pretty much the epidermis and right to the level of right at the border between what is dermis and epidermis. And then you have here the Paxinians, deep in the dermis. And remember, these receptors are what pick up vibrations. Okay, so now let's take a look at the nerve plexuses that occur in the body. And what is a plexus? It is simply a convergence of the ventral rami. You are familiar with that term, ventral rami or anterior rami, of adjacent spinal nerves, producing a series of compound nerve trunks. And here are the four plexuses, starting from cranial to caudal, cervical, brachial, lumbar, and the sacral plexus. The cervical plexus runs from C1 to C4. It is formed by the ventral rami, the first four cervical nerves. Primarily, they innervate the neck muscles. However, it also forms a nerve, the phrenic nerve, that's linked to your diaphragm. So here's the breakdown of the cervical plexus. And you can see some of the nerves. Here's the phrenic nerve. The risk that's involved with injuring the phrenic nerve is that can be life-threatening because the phrenic nerve is obviously linked to the autonomic nervous system. It innervates the diaphragm, and if there's an injury or in terms of a crushing of that nerve or whatnot, that can render the person incapable of breathing, and they're going to require emergency assistance and link them up to a breathing machine. So that's the cervical plexus. Brachial plexus, runs from C5 to T1. It's more complex, larger than the cervical plexus. It's located partly in the neck and in the axilla. Gives rise to nerves that innervate the upper limb. So the sequence of how these nerves come about, you have a root, then you have a trunk, then you have division, then you have a cord. A good mnemonic to help you remember this is that if you are really tired, you drink coffee or caffeine. Now cords, you have posterior cord, the big three cords, posterior, lateral, and medial cord. Okay? And they give rise to, for example, the posterior cord gives rise to the axillary nerve and the radial nerve. So it gives rise to two nerves. The lateral cord gives rise to half of a median or half the median, and it gives rise to the musculocutaneous nerve. The medial cord gives rise to or contributes to forming half of the other half of the median, and also the ulnar nerve. So again, the posterior cord gives rise to two nerves, axillary radial. Lateral cord gives rise to, contributes to forming part of the median and the musculocutaneous nerve. Medial cord gives rise to part of the median, half of the median, and the ulnar nerve. Now the reason why they gave these cords terms in terms of positioning, i.e. posterior, lateral, and medial, is because the lateral cord, the posterior cord, and the medial cord, they sit in their positions relative to this blood vessel here, the axillary artery. Okay, they are tagged as such, lateral, posterior, and medial, due to their relation to the axillary artery. So here are the cords, and here are the nerves that they give rise to. So lateral cord, posterior cord, medial cord give rise to these nerves. So the lateral cord gives rise to the musculocutaneous nerve, half of the median. Medial cord gives rise to the ulnar nerve and half of the median right here. And then the axillary nerve, the posterior cord, I should say, I'm sorry, gives rise to the axillary and radial nerves. So you have cords give rise to nerves. Now, I've in the ensuing diagrams, I've pretty much organized this to help you address your approach to studying or learning the innervation of the upper extremities, upper and lower extremities, I should say, in terms of you have the motor innervation and the cutaneal innervation. So the axillary nerve is going to innervate the deltoid and the teres minor, and this is the cutaneal innervation, this region that's shaded in here in orange. This is obviously sensory. Okay. Motor innervation, so the radial nerve is going to innervate pretty much the extensor group of muscles. The extensor group of muscles of the upper arm and the brachioradialis also. And here's the cutaneal innervation of the radial nerve. The musculocutaneous nerve, here's the motor innervation. That's going to innervate the flexor group of muscles of muscles of the upper arm. That includes the biceps brachii, the brachialis muscle, and the coracobrachialis. Okay, and this is the cutaneal supply. Okay, the median nerve, that's going to pretty much, it's wired to all these muscles here, a good amount of the flexor group of muscles in the forearm, and also some of the muscles in the forearm and half of the hand, as you can see here. And you can see the cutaneal innervation incorporated in these parts here. The ulnar nerve is going to innervate also the flexor group of muscles of the forearm, just like in the for the median nerve, and it also, but it obviously is not as many muscles as opposed to the median nerve. However, they are still muscles in the flexor group and the other half of the hand muscles, the hypothenar, lumbricals, and neurosii. Okay. And here's the cutaneal innervation. So on the exam, you should be able to look at a diagram like this and be able to determine the innervation. The radial nerve, we saw this one already earlier. This one innervates the muscles of the extensor group of the upper arm, but it also innervates the extensor group of muscles in the forearm. So the flexor group of muscles are innervated by the median and the ulnar nerve. The extensor group of muscles in the forearm are innervated by the radial nerve. And here's the cutaneal innervation. Now the brachial plexus also gives rise to smaller branches of nerves. You saw the major ones. Now these are the smaller branches. I'm going to give you a quick breakdown. I'm going to list here the muscles that are wired to these nerves. So for example, you have the dorsoscapular nerve that's going to innervate the rhomboids. The long thoracic is going to innervate the serratus anterior. The pectoralis muscles. So the pec major is innervated by both lateral and medial pectoral nerves, while the pec minor is going to be innervated by the medial pectoral nerve. Okay, so pec major, both lateral and medial. And for the pec minor, only the medial nerve. Then you have the cutaneal innervation of the upper arm, of the arm and forearm, I should say, and that's the medial cutaneous nerve. That's cutaneal, that's obviously sensory. Subclavian, that's going to innervate the subclavius muscle, very small obscure muscle that sits in the inferior border of the clavicle. Suprascapular nerve, that's going to innervate the supra and infraspinatus muscles. A couple of muscles of the rotator cuff group. The subscapular nerve has an upper branch or upper nerve and a lower nerve, upper and lower. Now the the subscapularis muscle is going to be innervated by both the upper and lower. However, the lower is also going to, aside from innervating the subscapularis muscle, it is going to also innervate the teres major. The thoracodorsal, finally, that's going to innervate the latissimus dorsi muscle. Okay? And this picture, this diagram illustrates these smaller branches, and here's the key, listing all those nerves. But again, my focus is that you know, in terms of the smaller branches, the muscles that are innervated by the specific nerves here. Okay, then you have your lumbar plexus, L1 through L4. The nerves that arise from that plexus, femoral and the obturator nerve. Here's the femoral. Here's the obturator nerve right here. Okay. Here's the motor innervation of the femoral nerve. Again, the nerve and all the muscles that it innervates here in the thigh, anterior thigh, I should say. And then you have here the cutaneal innervation of the femoral nerve. Obturator nerve is going to innervate the adductor group of muscles. Okay, and all the muscles here. You have your adductor brevis longus magnus. Okay, and also your gracilis. And here's the cutaneal innervation of the obturator nerve. Sacral plexus, L4 to S4. This is the largest nerve in the body, folks. It has two divisions, a fibular and a tibial division. So the tibial division of the sciatic nerve is going to innervate the hamstring group of muscles, biceps femoris, semitendinosus, semimembranosus. So it's going to pretty much target the hamstring group of muscles, and also the adductor magnus that has an adductor part and a flexor part. This is the picture, the image, the gross depiction of the sciatic nerve. Now, this muscle right here that I'm outlining, this is the piriformis muscle. The reason why I bring this up is because when this muscle becomes inflamed, it can actually compress on this nerve and cause a condition known as sciatica. Also notice the location of the nerve relative to some muscle, like here. This is the gluteus maximus here. It's been cut here and here. So the health professional needs to be careful when they administer an intramuscular injection to the patient, especially if they are down in the vicinity of the gluteus maximus, because by inserting, especially if it's a long needle, it can actually hit the sciatic nerve and cause problems. So the best site, the safest target site for an intramuscular injection for a patient would be up in the vicinity of the gluteus medius, which is way up here. So by you inserting the needle up here, you are well out of harm's way. And folks, that concludes my discussion of the peripheral innervation. Thank you for watching. Goodbye.